get started here. I call my talk Echocardiography and Heart Mechanics. What I'm going to do is go through the basics of echo first, and then you'll see I'm going to be doing we'll talk about heart mechanics, the way that the heart functions. And finally, how we use echo in cardiac amyloidosis that's different from the way that we use it in other diseases. Now, I've been doing echocardiograms on people like yourselves for 17 years in Dr. Marr's research lab. And when I first meet a person with cardiac amyloidosis, the first thing I do is ask them to just explain to me how what they understand about their disease and the way that echo works. I think that I like to see what people understand already and how they can express it, because I believe it's important that we understand our disease well enough to be able to explain it to others. I'm sorry, give me just a moment. My notes are hidden. And already I'll have to use these. So the basics of echo. Now, what you understand is that echocardiography is ultrasound. Ultrasound is a measure of sound waves. So the sound waves come through the transducer that I hold in my hand, and they go through the body and they reflect off of whatever's there. If you see these black parts, this is where the blood is pooled in the heart itself. The liquids don't really create echoes. The sound waves just go right through liquids. So this blood shows as black. All fluid shows as black on an ultrasound. On the other hand, when they hit a very solid sort of structure that's fibrous, they will bounce off that that structure completely. So all of the echoes come back, and that shows as white. And in the middle are the gray parts. That's flesh or soft tissue, because some of the echoes bounce back and some of them go through. And every time an echo finds a spot that it reflects off of, it puts a dot there on the screen. And all of those dots together add up to the image that we see. Now, another thing to remember is that the ultrasound waves don't like bone and air. So the lungs and the ribs kind of get in the way when we're doing an echocardiogram. That's why I always ask folks to lie on the left-hand side, and I point the echocardiographic probe, the transducer, at the heart in 3 different directions. Now, not only does the ultrasound show images, it also shows movement. I want to ask, has anyone noticed when a train is approaching you at a track, it comes at a really high pitched sound, and it gets higher and higher and louder and louder. And then when it passes you, it goes boom and gets to a lower sound. That's because sound waves are affected by movement. So a moving object creates and interacts with sound differently. And the ultrasound machine can interpret that. I have here a video of the what we call color Doppler. These are the valves in the heart reacting to a setting that I put on the machine called color Doppler. And I ask the machine to show me all of the movement within this block here that is moving within the range of frequencies that blood will move through a valve. The red flows up towards this transducer, the probe on the top, and the blue flows back. In this case, this is the mitral valve flow, the red, and the mitral valve regurgitation, when it leaks back just a little through the valve. And on this side is the tricuspid. And notice over here on the right, whenever I put my probe right on this plume of flow, it makes a graph down below, and I'm able to see how fast that blood is moving, the pattern of flow, and the timing. And all of those are used in the interpretation of the echocardiogram. So that's, we've seen structures, images get created by sound waves. Now these are patterns of flow, both in color and in a graph. And another kind of graph we show, I'm going to show a little animation to get us thinking about the way that the heart moves. So as you see from this little cartoon here, not only is the heart squeezing, but where's it going? My little cartoon stopped. Come on. Well, I'll just do. You can see as it squeezes, it bounces down, and then it bounces back up. So I can put my ultrasound probe right on the flesh of the heart, and sure enough, it shows me that bounce. Now, that bounce of the heart is what we call tissue Doppler, and that's also important for understanding how relaxed your heart is. So that's the very basics of ultrasound and the way that we use ultrasound on the heart. Now I want to get into a little talk about heart mechanics. That is, how does your heart actually work? I like to say that the heart is like a duplex house. Now I know I use a lot of analogies, but I just find it's easier to understand things in simple terms. So a duplex house, as you know, has a wall down the middle and it's two separate dwellings. In this duplex house, there's just two rooms on each side, a front room, a smaller front room, and a larger back room. Now, the blood flows in through the front door into that front room, and when it's full, then the doors pop open and it goes into the second room, which is the ventricle, and then out the back door over to either to the body or the lungs, depending on whether it's the left side or the heart side. Let's look at this drawing of the heart here. We've got a front room here on the left side. I know it's on the right side of the screen, but that's how the heart is usually shown in illustrations. The blood is rushing into the heart through these pulmonary veins here, and it enters from the lungs, the oxygenated blood, into this front room. And again, when those are full, the doors just flap open. And then the blood flows into the left ventricle, fills up that space, and then it starts acting like a compactor and squeezing the blood out. And this mitral valve here, since it's like a double door, it closes, and it tries not to let any of the blood back through to the first room, but out the back door to the aorta, which is here in this picture, where it goes up to the brains and to the kidneys and around to all the other bodily organs. And then the right heart side works the same way. The blood flow comes in through the superior inferior vena cava. That's a vein that flows into your right side of your heart. And it comes into the right side of the heart here in the atrium and flows through in the same way out to the lungs to get more oxygen. If there's one thing you have to remember about this, is that the heart is the main engine in an oxygen delivery system. All of this physiology, everything we understand, and everything that the heart does is about getting oxygen to the tissues. That's its primary purpose. It also carries a lot of other things. As you all know, it carries a little protein called TTR, and it carries light chains. It carries other proteins that do bodily functions. But the thing that rules it is the oxygen. And let me move on to the next slide. Take a break from all the explaining and just watch as this heart beats. This is a heart with amyloidosis, and it is, as you see, that in this case, the front rooms here, the atria, are not really all that much smaller than the back rooms because these atria swell up because, again, blood doesn't get effectively into the heart as much. What we understand about this heart is that it's thickened. That isn't the normal thickness of a heart wall. And there are a few other things that I can explain as we move on. But the most important thing to take away about this part of heart function is the thickness of the wall matters. Thicker walls equals less space. Remember how I said this black part was blood? There's less blood here than there would be if these walls weren't as thick. The less space you have, the less blood fits in, the less oxygen gets to the heart. That's the main way that the thickness affects the heart function. Now, I know that everyone in here has asked their doctor at some point or other, what is my EF or ejection fraction? Ejection fraction is a number that measures 1/2 of heart function, part of the picture. It takes the blood flow in and divides it by the blood flow out. So it's only a percentage of the flow. I think I might have that reversed there, but EF is only the percentage of the flow. It's not the amount that gets through. Looking at the way that I measure EF gives you a little more insight. See this grid pattern here? This is me measuring the left ventricle in what we call the 4-chamber, that 4-room duplex house I showed. This is in diastole when it's full, and this is the same measurement in systole after it's squeezed. So how much gets in and how much gets out? The percentage of those two is ejection fraction. Well, look at this heart here. It's 52%. In spite of how thick-walled it is, it's beating, it's squeezing fine. 52%, 55 is completely dead normal. So the issue here isn't the percentage of blood flow here, but the stroke volume. There we have a 35% stroke volume, and normal is 60 to 70. So there's less work happening in this heart because of the amount of blood flow through the heart. I just let me back up a little bit here. The ejection fraction is just that measure of flow out through flow in. And as I said, the ejection isn't the be all and end all. The outflow is only half of the picture in this case. In order to understand inflow and outflow, it's easiest to think of two kind of pumps that you already know. The first pump is like a hand crank water pump. If you've ever used one of these, it's really hard to get the water flowing. You have to pump really hard until the water starts flowing. Then the water flowing in does half the work of the water flowing out. This outflow is really critical, and it's what we always think about in terms of a water pump. If you were filling buckets up to fight a fire, you'd be very concerned with how fast the water is coming out of that spigot. On the other hand, if you look at a sump pump, then in that case, you're not really concerned so much about the water outflow. You're worried about the inflow. You want to see how well the pump pumps in the water from the basement. And that's one of the main thing I'm trying to get you guys to see is that the EF only measures outflow. And if we don't pay attention to the inflow in a sump pump, then our basement gets flooded. And that's similar to the way that the heart pools fluid. if enough doesn't get in and get through, it pulls it around the lungs, transmits it down the legs to the ankles. Now, let's get in a little bit to the nitty-gritty, and I want to see how you guys recall ever seeing an image of the heart muscle. This is, in essence, this is the heart wall, a drawing of the heart wall. Now, you've all heard of heart failure, and most of the time we think of heart failure, and everyone out in the world thinks of heart failure in terms of coronary artery disease. And the terms heart attack and stent, blockage, these all refer to coronary artery disease. That's when the blood flow is blocked and the muscle grows weak and thin. In amyloidosis, the blood flows in fine, but the amyloid builds up between each of these layers of the heart. So not only is it thicker and has less room for the blood to flow in, but because it's in between every layer, it's hard for it to squeeze the way it should. And the heart really squeezes like this. It not only is squeezing in, but it's turning on itself. And all the layers of muscle have to slide on each other in order for the heart to really effectively pump. And that thickness and stiffness is the central ways that the heart affects. The amyloid affects the heart, both in AL amyloid and TTR. Going back to thickness, I want to demonstrate that these two hearts, one without cardiac amyloidosis and one thickened by cardiac amyloidosis, which one looks like it holds the most blood? If of course, the one on the left is got a lot more space for blood to flow in than the one on the right. And that's the basics of ejection fraction and also the way that coronary artery disease differs. It's a thinner heart that doesn't pump as strongly, as forcefully. Now, I've talked a lot about what we don't measure as effectively and as frequently in cardiac amyloidosis, and that is ejection fraction. So now I want to talk a little bit about what we do measure and some of the particular measures that are really particular to cardiac amyloidosis. First, of course, I've already said is wall thickness. We measure how thick the wall is. In this case, this blue line tells me that this wall is 16 or 17 millimeters. And here, this one is about 11 or 12. That is the sort of line that we use, the number that we use to see, well, is this maybe cardiac amyloidosis? The thickness that the magic number is 12. If something is 12 millimeters, then we put cardiac amyloid in that list of things that might be wrong. Before that, all of the normal hearts you see are generally below 1 centimeter. A little bit thinner in women, but that's another discussion. The second thing that we really pay attention to, as I said, is the relaxation of the heart. And you saw this picture before when I put the mitral valve, I put the ultrasound on the mitral valve annulus here. It shows me that bounce that we talked about before. Notice how these waves, none of them go above 5. There's a sign or a sort of a shortcut way to diagnose amyloid. Folks say that If all of these are below 5, 5, 5, and 5, then do you want to put amyloid on the list of things it might be? Over here on the right is the heart of someone that we thought might have cardiac amyloidosis because their walls were thick enough. But look what happened whenever I put on the tissue Doppler. All of these waves are above 5. Now, that's not enough to prove they don't have amyloid, but that was one of the clues in that person's heart. And that's one of the other things that we look at carefully when we're looking at a heart to see if it may have cardiac amyloidosis and to measure how it does over time. Now, for the last image, I want to show what we call strain imaging. Now, I know this is a very confusing image, and I wouldn't have time to explain everything about this image, but I just want to give you a general notion that this is a measure of the movement of the heart, but in a very particular way. In strain, we tell the machine to go in and it identifies every tiny part of the heart, every little bit, every molecule in there is identified, and then it's compared to every other bit that's been identified. So you have 1,000 little points of light in there, so to speak. And what strain does is that it measures how far apart they are at one part of the cycle and how close together they get. So remember how I said the heart works like it twists and moves and slides on itself, and it's also thickening and moving? Well, if you can measure every point in the heart in relation to all the other points around it, then you can get a very complex, very multifaceted read on how the heart is doing. And it breaks it up into segments here and tells me. Now, because you're measuring how much the heart squeezes, you start with something 10 centimeters apart, 10 millimeters apart, and at the end, it's 3 millimeters apart. That means it's 7 minus 7. And strain is measured in a negative number. And of course, the bad news, as I've said, is it's very complex, very difficult to understand. The good news is that it boils down to a very simple picture. This is what we call bullseye in strain. Now, have you ever seen one of those collapsible drinking cups? You just sort of shove it down from the top, and it's like a lot of rings that you can pull up. And that's what this is trying to demonstrate. Notice how it's like a dartboard. This little 100-point circle in the middle, that's the very tip of the heart, the apex. And then as you go down the heart, you move to the concentric outer circles, and the outermost circle is the base of the heart near the mitral valve. And what we see on the left here is a classic pattern for cardiac amyloidosis. And that is called cherry on top. It's, as you can tell, reddest on the first ring, and then it gets pinker and pinker and pinker until it turns into blue. On the right-hand side, on the other hand, we have the normal heart that is pretty much all red. And you can see that there's still a range between the highest number and the lowest number. In this case, it's right on this side of the wall. It's more dramatic because something's going on in the anterior wall of this heart. But in general, there's only about 10 points difference. But here we're going from 22 to 2. That's 20 points difference. So the ratio of difference between the strain at the end here, the apex, and around the base tells us about the severity of the effect that amyloid has had on this heart in terms of strain. Now, I hope that hasn't been too confusing for all of you. I have other pictures we can show, but I wanted to stop there and start a discussion session and ask if you guys have any questions or clarifications. Some of you did send some questions in, and thanks very much, and I'll try to get to those as well. All right. So let's get to switch to Margie and see if if you had any questions come in the chat.
Thanks, Steve. That was great. I don't see anything in the chat yet, but I just want to say Dr. Moore came too, so he's available for Q&A as well.
Yeah.
But that's great.
I'm sure everyone's thrilled to see Matt. And many of you may have questions about studies and about other things that don't have to do with echo. And we'll welcome those, but I'd first like to hear from folks that have questions about what they've seen, something they've ever heard on their echo, any clarification I could give. Now, does everyone see a raise your hand button on the bottom of your screen, or the chat? In the chat, you can send a message to everyone. Someone's
And Steve,
asking,
asked if oh, I don't know if you can see the question. Does every echo measure strain?
Very good question. They all don't. It's not something that's in every machine. It's, as you saw, the EF, the tracing the EF is very elementary. But that's been around for a very long time. Strain is a newer phenomena, so it's not standard in every echo lab. Matt, you may want to say something more about that.
No, I think you're correct. Many echo labs do it, but not everyone, and the doctor needs to usually request it. Doesn't take a lot of extra effort. Anyone who's undergoing an echo in our research lab does get strain measured. You have to have a certain type of echo machine. Most of them are able to do it, and it's become a standard approach.